Welcome. It's a fantastic pleasure to welcome all of you to this valedictory lecture. I'm particularly delighted to welcome Professor Spearman's family, her husband Jonathan, her son Julian, and daughter Rebecca. And I'm sorry that her other son Lawrence is not able to be here today. I'm also delighted to welcome Dr. Bhavna Patel, our previous CEO, and Dr. Bernadette Ike, previous COO, as well as Emeritus Professor Solly Bennett, previous Chair of Medicine. For me, it's an absolute delight to be able to make a few introductory comments about a colleague, a friend, a clinician, a scientist who is deeply respected in our midst and somebody I immensely cherish, a real mensch. Someone who has dedicated her entire career to the care of patients in this hospital. As a young registrar, I came across the words of an anonymous 16th century physician who has oft been cited. On the role of a physician, he stated, to cure sometimes, to relieve often, and to comfort always. Today, we celebrate a colleague who has been the consummate physician, without fail, providing cure, relief, and comfort to countless patients. Catherine Wendy Spearman graduated with an MPCHB from the University of Cape Town in 1982. She worked as a medical intern in this hospital. Between 1984 and 1986, also worked as a medical officer in this hospital before joining the rotation. And between 1986 and 1990, was a medical registrar. She graduated as a physician, a fellow of the College of Physicians in 1989, and this was shortly followed by a graduation from UCT with an M.Med in medicine in 1991. Between 1990 and 1993, she was a registrar in hepatology, and in 1992 was appointed a consultant in pediatric liver transplantation at Red Cross Hospital, an appointment she still holds. In 1994, she was appointed as a specialist in the liver clinic at Groote Hospital while doing research in the MRC Liver Research Unit. And in 1998, appointed as the lead clinician for liver transplant at Groote Hospital. At the same time, she was also appointed as the head of the Division of Hepatology at Groote Hospital and the University of Cape Town. This would be followed by graduation from her PhD in 2008 on a project titled The Effect of Two Novel C-Type Lectins, BA100 and BA25, isolated from the venom of a puff adder. She was promoted to ad hominem professor in 2018. Wendy has distinguished herself as the doyen of hepatology, not only in South Africa, in Africa, but is also respected as a key opinion leader in her discipline with a substantial global presence. She has in many ways been the ambassador for her discipline in this country and beyond. She's a living scholar on liver disease, particularly from sub-Saharan Africa, and has published extensively in her discipline with high impact, and her work is highly cited. She's a wonderful and committed teacher who has shaped generations of doctors and physicians within our department and beyond. She's been a very popular teacher at undergraduate and registrar level, often winning the award for best teacher in our department. She has trained 4 hepatology fellows, over 20 GIT fellows, countless registrars, and has supervised 9 masters and 2 doctoral students to completion. As you will all know, she established the first viral hepatitis ECHO program in sub-Saharan Africa, and this program has been highly impactful. For her expertise, Wendy has been on guideline committees on management of hepatitis B and C for the World Health Organization, which she currently co-chairs, the Southern African HIV Clinicians Society, the World Gastroenterology Organization, and the South African National Department of Health. She is currently the Vice President of the Society for Liver Disease in Africa and sits on committees for essentially every society concerned with global liver disease. Recognized by her peers for excellent scholarship and impact in her contributions, Wendy has multiple awards and fellowships by election. Last week, at the annual meeting of the European Association for the Study of Liver Disease in Milan, Wendy was awarded the inaugural International Liver Health Advocacy Award in recognition of her outstanding medical and scientific contributions to the field. On a personal note, Wendy was one of my favorite lecturers when I was an undergraduate student. She was one of my favorite consultants when I was a medical registrar, and has been one of my favorite colleagues in the department. Her contributions to leadership at every level have been immense. Her commitment to high standards of care have helped all of us to constantly up our clinical game. As head of department, I have valued her quiet confidence, her calm and reassurance, and always her wit and solid advice. Wendy, I would like to congratulate you on a most successful clinical and academic career. You have been a model of how to handle a successful professional life, alongside a fulfilling and admirable role as a loving mother and a doting wife. I wish you well in your retirement and hope you will have more time for surfing and diving. I'm delighted especially that you will not be leaving the department and will continue to contribute to our life and work as Professor Emerita and as a senior scholar at the University of Cape Town. I would like to invite Mark Sonderup to now come and make a few remarks.
I said to her, you know, you retire in 5 years' time. And it sat there and it felt such a far way away. And yet in the blink of an eye, here we are. So time wait for no man, as they say. And perhaps out of many, from a working point of view, I've worked with Wendy for 22, 23 years. So I think I am ever so slightly allowed to have some insights and make some comments. But I'm going to start off firstly because if you allow me the next few minutes, this is not going to be about me. I've actually invited a number of people to make some comments. But first of all, I thought we would start with Wendy, and I'm going to think about the last 22, 23 years. What does it sort of encapsulate? But this is by no means exhaustive. So first of all, willingness. And I think it's that willingness to help always. The E is clearly endurance and ethical, but let me tell you about endurance. And for those interns that give me sick notes because they have diarrhea, this is a person who finished the ward round, left, and in fact went off and delivered Rebecca. So don't tell me about endurance until you've done that. Nurturing, in the true sense of the word, helpful, caring, kind. Dedication, I think that speaks for itself. Dedicated to colleagues, patients, the institution. And integrity, and I think that's a word that'll come through quite loudly. So that's my little attempt last night at trying to find some words that make up Wendy. But let me start off kind of maybe right early on, and here come the people that I want to sort of bring in at this point. So firstly, Mark Blockman, and Mark has apologized for not being here today because I'd actually asked him to say a few words. And the reason I asked Mark was because Wendy did mention to me, I was saying to her, who do you remember the longest in terms of just being around? And she said, in fact, it's Mark Blockman, because she remembers him being the pharmacist up in the old main building when she was a medical student on the ward. As we know, Mark started out life as a pharmacist, perhaps much like myself, and then saw the light. So, Wendy, I'm not going to read this extensively, but Mark has penned a letter. And just to highlight a few issues, he said, my dearest Wendy, I'm sorry to not be able to be with you today to share this important occasion, but so happy that I can share some words. Importantly, Wendy and I share a birthday, so we're in fact birthday twins. And in fact, it's Mark's 60th birthday next week, so he's not around, but send him a message to wish him happy birthday, and yourself, Wendy. So he says, I've known Wendy for ages, since the old hospital days, being the pharmacist there, and she has and always will be Wendy, a person of enormous integrity, very humble, an excellent doctor. She's extremely thorough and so very empathic. Wendy believes that listening to patients is vital to being an outstanding clinician, always placing the patient at the center of care. I'm privileged to regularly be reminded of this when Wendy asks for the release of various medications. It's always about the patient and in their best interests, and it's therefore very difficult to say no. She epitomizes Ubuntu. Wendy is deeply involved in undergraduate teaching, and Tobacco just mentioned that, and postgraduate training in hepatology. Wonderful teaching skills, brilliant mentor, and I can speak to this aspect from being taught by her and my own deep connection to the student support processes within the faculty. In conclusion, and Wendy, there's many more, but I'm going to leave the letter with you. In conclusion, I'd like to reiterate that her contribution and commitment to all that she teaches and mentors and the patients she looks after is admirable, and often Wendy will go beyond the call of duty. I wish you so well for the next phase of your great adventure. Much love, Mark Blockman. So I thought Mark would be a good place to start. But in the prelude and the invite, I think Wendy mentioned that Simon Robson was involved. So some of you may recall Simon, remember Simon. He's now still in Boston, the USA. So first of all, and I don't know if it's ChatGPT, Jakub, I know you wrote something today and you said it wasn't ChatGPT, so big up to you. But I don't know if this was ChatGPT, but Simon sends you a sonnet, Wendy. At Grooteskier, where transplants shine bright, there reigns a scholar of hepatology, whose name reflects light. I'm not doing anything, it's the system. Maybe it's reflecting the light. In realms of complex liver phenology, in the clinical realm, she always did care, promoting the liver porphyria and transplant quest. Her knowledge vast, her dedication rare, always a beacon for the sick and dispossessed. A fellowship completed some while ago, under Ralph and my assisting hands. In Puffad a venom she did show, new insights into immunosuppressive strands. With kindness and grace she leads with steady hands. Her dedication is a great gain in Africa lands. That's from Simon. So I'm not doing anything now other than trying to just create a little bit of light so we can move onwards, because you'll see what this is going to need. So Wendy, firstly, from Simon.
Hello, everybody in Cape Town. Greetings from Boston. My name is Simon Robson. I had the great privilege of working with Wendy Spearman in our formative years in Cape Town, not that long ago. First, congratulations, Wendy, on this day of your valedictory lecture. How time flies. Second, despite time flying away, you're far too youthful to step away from this. You've achieved what has been a higher calling for all of us, a true vocation. They say a hobby is fun, a job is clearly necessary. A career can be great, but it's not essential. We all try to achieve a vocation. That's forever. It can never be taken away from you. And it's really a high mark of what you've been able to do during the last 30 years. Your accomplishments speak for themselves in the basic science arena. purifying, characterizing these immunosuppressive lectins from puff adenovenom, your work in transplantation, immunosuppression, looking at cytokines in bile. I remember from all those years back with major presentations in Europe in this area, the work in viral hepatitis, and then more recently in metabolic dysfunction-associated liver disease, and the clear advances in the nomenclature that you have achieved as part of the core committee for these changes. These are many achievements and accomplishments of which anybody would be proud. I still always think of you, though, Wendy, as the soft-spoken, very young, diligent, and fearless hepatology trainee who went on to achieve major accomplishments and took hepatology to a new level at Groote in Africa and beyond. So congratulations, Wendy. Have a wonderful day, and let's meet soon. Hopefully not longer than a few more years. All the very best. Bye-bye.
So moving along, we're going to move to another colleague of ours and Wendy's over the last few years. This is Professor Mary Afihene from Ghana.
My name is Dr. Mary Afihene, a gastroenterologist in Ghana, West Africa. I'm delighted and honored to send this message towards the introduction of our esteemed valedictorian Prof. Wendy Spearman. I have had the opportunity to work with Wendy in the area of hepatology in the viral hepatitis in Sub-Saharan Africa Eco Clinic, the Gastro Foundation of the Sub-Saharan Africa, and Gastroenterology and Hepatology of Sub-Saharan Africa. She has an outstanding and profound knowledge, insight, and experience in hepatology and medicine in general. So many doctors globally, including myself, will attest to this and have benefited from her willingness to share and disseminate knowledge. I join in celebrating her exceptional academic excellence, dedication, hard work, and significant contribution to the field of hepatology. I wish Wendy well and all the best in her post-retirement, although she is not tired. Thank you very much.
So there was Mary's message. Retiring but not tiring. Then moving on to London from Jeff Dusheko. Many may know Jeff in the audience. Jeff has become a fantastic colleague and very supportive of our ECHO programs and other endeavors, and now an honorary professor at the University of Cape Town.
I'm Jeff Dusheko, Emeritus Professor of Medicine at University College London, and I know Wendy well. Wendy Spearman is a uniquely qualified physician and hepatologist who has straddled both adult and pediatric hepatology and transplantation at Groote and the Red Cross Hospital with considerable expertise for many years. And there are few hepatologists that I know who could lay claim to such expertise and commitment. Few individuals in the region can have a deeper grasp of the problem of liver disease than Wendy Spearman, given her undergraduate and postgraduate career, which have been firmly rooted at UCT and Groote Hospital. She has, amongst other things, been responsible for important position statements that are changing practice in hepatology in Africa and have brought consensus and unique protocols to regions that do not have the option of simply implementing the protocols written for high-income countries. And all this has been done in an academic environment which cannot be easy given her clinical workload. She's achieved international recognition for her work. For example, she recently chaired the WHO guidelines group on hepatitis B, and fittingly, last week, she was awarded the European Association for the Study of Liver Disease International Liver Health Advocacy Award, and I had the privilege of introducing her. She's driven outreach programs in viral hepatitis and liver disease, and together with younger colleagues and peers in South Africa, with whom she has fostered a remarkable, enviable, and durable academic and collegiate partnership, has driven these programs with much success. I and others regard Wendy as a role model for women in medicine and science and regard her achievements with admiration and esteem. Her maturity, experience, nous, worth ethic have rightly been utilized by the university to develop training and policy to meet the changing needs of medical schools in South Africa and have ensured that UCT will contribute to community health outcomes. She will be a continuing asset to the department and to her institution. She indeed is a jewel of the department to be treasured. Thank you, and good luck, Wendy.
So thank you, Jeff. And as Jeff and Tobeko both mentioned, this was last Thursday, exactly a week ago, when Wendy shared the award with Manal Al-Sayed from Cairo, in fact presented by the European Association for the Study of Liver. Quite an achievement and a very auspicious occasion, and shared the stage with some luminaries from around the world. So having said that, as I said, her and Manal were awarded International Women's Day Award earlier this year, and have shared this accolade before because they both head up, co-chair the Society of Liver Disease in Africa. So I thought we really have to hear from Manal, sitting in Cairo.
I had the pleasure of knowing Professor Wendy Spearman for the last few years and working with her very closely. We became great friends. I think we complement each other somehow, and I'm sure she's going to enjoy a little bit of her retirement. She dedicated all herself and her life to her career, to her work, to the patients. She's very compassionate, and she's very passionate also about her work. And I really have the pleasure of continuing to work with her. I think we still have a lot to do together, and I look forward to continuing working with you, Wendy. Happy retirement.
So I'm going to finish off, because this is not my lecture, with Sanjeev Arora, who's the founder and director of Project ECHO. I think many have mentioned Wendy's spearheading of Project ECHO, and several other people in our department have taken it up as well. And it really is an international movement, and I thought we would get Sanjeev because I don't believe there's anybody else that we've shared a more uncomfortable taxi ride with than Sanjeev Arora. And if I dare to disclose, we were so cramped into a taxi in Boston, Wendy had to sit on Sanjeev's lap. And I don't know who was more embarrassed, Sanjeev or Wendy. Thank goodness it was a 5-minute ride and we could get out there quickly. But let's hear and finish off with Sanjeev.
Hello, and greetings to all of you. I met Wendy many years ago at an international liver conference. She immediately saw the possibilities for the ECHO model in helping her expand her mission, her impact, to treat viral hepatitis in South Africa and far beyond. To get started, Wendy and her team traveled all the way to Albuquerque, New Mexico, in Southwest United States in November of 2016 to train on the ECHO model. When she went back to the University of Cape Town, she and her colleagues set up a viral hepatitis ECHO that has trained thousands of doctors and helped patients across South Africa and the entire African continent. These patients of doctors trained by Wendy Spearman get timely and quality treatment and care. When the pandemic started, Dr. Spearman and her team adapted the virtual mentoring community of practice they had created for treatment of viral hepatitis to educate providers about COVID-19 in an ever-changing knowledge environment. In 2022, Dr. Elizabeth Cluett and I had the opportunity to travel to Cape Town and participate in Dr. Spearman's ECHO. On that trip, Dr. Spearman showed such kindness and leadership, introducing me to leaders of the Western Cape and other academic institutions in the area, to help them think through how the ECHO model might be of use to them to expand their impact on their communities. Wendy has had a huge impact on her community. Her generosity of spirit is a source of great inspiration for me. She is a leader in the global ECHO movement, which now has 5.8 million learners in 207 countries. She has changed how thousands of providers treat patients and has impacted the lives of tens of thousands of patients. Wendy, thank you so much for your friendship and truly embodying the values and spirit of ECHO. I wish you all the best in the next phase of your life. I know you'll do amazing things in whatever you take up.
Thank you, Sanjeev. So I'm going to finish up. As I said, this wasn't about what I'm going to say. I've asked other people to speak in our stead from around the world. It's just a smattering of people. But if I just have to have a personal reflection, it made me think of this last night because I was using this particular quote a long time ago. In fact, it was at the end of 6th year at graduation. And there was a book in 1985 called City of Joy. It became a subsequent film in 1992. And the film is about a doctor refinding themselves in the slums of Calcutta. And the character in the film is a chap called Hasari Pal. And he's got many memorable quotes in the book and in the film. And this is one of them, and I think this perhaps for me best summarizes Wendy. And the quote really is, all that is not given is lost. And that's perhaps what really summarizes Wendy in one little line. She's somebody who gives because in believing in giving, it's going to be lost. So at that point, I'd really like to hand over to the person who should be speaking today. And at this point, Wendy, I'd like to invite you up to present your valedictory lecture, please.
So welcome, everybody, and thank you for those amazing tributes. It's really quite overwhelming, and I think every day I wake up, I enjoy where I am and where I work. And so I think I'm going to be going over, but I'm going to take about 45 minutes to take you on the journey, or my journey as a hepatologist through the decades, and really show what an amazing journey and how privileged I've been. So I'm going to look at influences of my career, particularly look at the changing epidemiology of liver disease, the involvement of diagnostics and therapeutics, liver transplantation, and then briefly touch on the importance of regional collaborations and outreach programs. My career starts here in 1977 and will temporarily end at the end of this month. And so I've been a lifer. And my first job was given to me by Prof. Benetter as an intern. And I was given 10 months in surgery with only 2 months in medicine at the end of the year. And at the time I thought this was catastrophic. But when I look back, I realized that it has a major impact. It made me realize the importance of the interaction between medicine and surgery, collegiality, who we need, when we need to ask for help, who we should ask for help. And I think this has had a major impact on how I practice medicine, hepatology, and particularly liver transplantation. And I've been extremely fortunate to actually, for my whole career, work in liver disease here at Groote and at UCT, and really thank Professor Ralph Kirsch for actually employing me as a hepatology registrar in 1990. And you'll see how he influenced me. So I've really been fortunate to actually have known and worked with 5 heads of clinical medicine, all of whom have had unique styles of leadership, and all have had an impact in terms of my career. So we started with Solly Bencher, as I mentioned, told me that I could have a job as an intern. As a registrarship, he did mention maybe going to Tygerberg, but we kind of persisted, and I got my job at Groote. And then Ralph Kirsch, who I complained that in 4th year that I hadn't given a good enough mark, and Ralph just said, that's fine, just push on, as Ralph would do. And then Prof. Saunders, who I first knew as a student, and then came to know clinically when I was a junior registrar looking after his mother. And I was really petrified that something would happen to his mother on my watch. And subsequently, he became a great mentor, colleague, and friend. And then to Professor Mayosi and Professor Natuzzi, who've actually known me as heads of medicine and have really been strongly supportive, particularly in our quest to actually have liver disease becoming recognized as a subspecialty. So to all these individuals, I owe a great debt of gratitude. But I think it's really important to acknowledge the early influences. So I want to really acknowledge Drs. Helen Brown, Kavi Kavadis, and Aziz Abu. They were all superb clinicians, but taught me the importance of listening to the story of the patient, paying attention to clinical detail, and always to be actively involved in the care of your patients. And so in terms of just giving an anecdote about Kathy, and our post-intake ward round, it was essential that every patient had a manual ESR, white cell count, and urine checked. And if you hadn't got that, you were there for the high jump. So you made sure that everything was in place. And then Professors Kirsch and Robson, who really inspired my love of the liver and introduced me to the rigors of clinical and translational research. And so I was extremely fortunate to be a fellow in the very heyday of that liver research center. I did my MMed and PhD, as you heard. And importantly, we had to every Monday report back on our findings. And this was really quite stressful because for many years I had nothing to report. But Ralph would actually always say, just press on, the results will come. And I really have to thank Enid Shepherd, Simon Robson for being my supervisors. But nothing can be done alone. And so Helen Buerters and Vivian Woodburn, who were really helpful and really instrumental in helping me in the lab. And then Lavinia Peterson, who knew I was a terrible typist, helped me in typing up these theses. So I owe a great debt to all of these people. And I grew as an individual in terms of being a translational scientist. I think it's very important to acknowledge the days of the Porphyria lab where we actually were involved actively in searching for that elusive gene. And so Ralph Kurz, Pete Meisner, Richard Hiff, and Corrigal, together with Harry Daly, were responsible for identifying that first mutation associated with varigate porphyria, the R59 mutation. And this is found in 95% of our South African VP families and has really changed how we manage and identify patients with this mutation. And it was reported in Nature Genetics in May 1996. And this was a time of really great excitement in the lab. And we have definitive treatment for porphyria, particularly acute hepatic porphyrias. Givarasan, which is a double-stranded small interferon RNA, given at 2.5 kilograms subcut monthly, and it specifically targets that ALA synthetase, leading to significant reduction in acute attacks in patients. And this is a result of actually decreasing the levels of the ALA and PBG by 94%. But importantly, the impact on patients. Those in this trial experienced 70% fewer attacks requiring hospitalization, and 50% had no attacks compared to placebo. But look at the cost, $43,500 for one injection. And once again, this really shows the inequity. We need to actually ensure that patients who can have these life-saving or life-altering treatment have actually access to something that is affordable. And then Red Cross Children's Hospital. Began as an SHO in 1985 and really convinced me that I wouldn't become a pediatrician. And yet, I became actively involved in the pediatric liver transplantation from its initiation in 1991. And I think this has greatly enriched my career as a hepatologist and helped to ensure good outcomes with adolescents transitioning to adult care at Groote Schuur. And so once again, I owe a lot to Professor Alistair Miller, who led this team, to all my colleagues, the surgical colleagues, our medical colleagues, the transplant officers, traveling a long road, looking after patients, the ups and downs, and it has been an amazing joy to me to be part of this team and ongoing. And so just looking at liver transplantation at Groote Schuur and Red Cross Children's Hospital in the early days, the liver unit, together with our hepatobiliary and liver transplant surgeons, pediatricians, critical care, anaesthetists at both GSH and Red Cross, pioneered liver transplantation in South Africa. The first successful liver transplant was performed in 1989, and she survived 7 years on immunosuppression consisting of steroids, cyclosporin, and azathioprine, and she died from an MI. The first living-related liver transplant in South Africa was performed in 2002, and she remains alive and well 22 years post-transplant. But of note, we've had 16 pediatric liver transplants. We've reached adulthood and have had successful pregnancies. Not always what I wanted, but they've done extremely well. And so now I usually just tell them, just tell me when you're pregnant and I don't have to stress, I just have to manage you. So our longest surviving adult is now 44 years and our pediatric transplant 33 years. But the evolution of immunosuppression and appropriate antiviral prophylaxis for CMV, EBV, and hepatitis B has really enabled us to have 1 year survivals of greater than 85%, 5 years of 75%, and 10 year survivals of greater than 65%. So since July 67, when Thomas Stiles performed that first successful liver transplant, there's been an amazing evolution of immunosuppression, and I've actually seen this happening in front of my eyes. It's changing from maintenance, cyclosporin, steroids, and mercaptopurine or azathioprine, using rescue therapy, which involved high-dose IV Medrol, an OK3 and anti-CD3 antibody, with the devastating consequences of post-transplant lymphoproliferative disease driven by EBV and CMV hepatitis, often resulting in chronic ductopenic rejection and graft loss. And so we've seen this advent of tacrolimus in 1994, basiliximab in 1988, and mycophenolate in 2000. But the access to this drug was often not easy. If we look at the journey of tacrolimus to Cape Town in those early 90s, had to leave Osaka in Japan, go to Frankfurt, then to Johannesburg, and eventually to Cape Town. And this took about 3 weeks. And that was obviously rather problematic if you had a patient with acute cellular rejection that required rescue therapy. So the way we went around this was actually to make sure we always had at least 6 weeks supply of this drug. Probably wasn't allowed, but in fact it enabled our patients to survive. And so we really transitioned from death, from graft failure to death with a functioning graft. So looking at liver transplantation in the 21st century, we are seeing changing etiologies, with most now being due to alcohol-associated liver disease or metabolic dysfunction, steatotic liver disease, with the complications of cirrhosis and liver cancer. We're now seeing expanding indications for transplantation, particularly in the field of malignancy, liver cancer beyond the Milan and Toronto criteria, perihara cholangiocarcinoma in the setting of neoadjuvant chemoradiotherapy, and unresectable colorectal liver metastases. And also early transplant for severe alcoholic hepatitis, where the suitability is not only decided now on that 6-month abstinence rule, but always the demand will be beyond the supply. So we look at expanding the donor pool. There's the use of viremic donors, particularly HCV-positive donors to negative recipients. And this has been enabled by the seemingly accessible direct-acting viral antitherapy, which can be used preemptively, postoperatively, to prevent reinfection of the graft. The role of machine perfusion of organs from deceased donors. This allows assessment of graft viability, particularly for marginal grafts, and delipidation of steatotic grafts. It also lowers the risk of non-anastomotic biliary strictures following donation after circulatory death, and then always this quest for xenotransplantation. But I think we need to remember we live in a continent where access to liver transplantation is very, very limited. And so our goal needs to be to actually identify those with liver disease, prevent it, and treat it appropriately so we can avoid the need for liver transplantation. And I hope I'll show you over the past, since 1990, the strides that have been made in medical therapy. So importantly, this comes down to how do you assess liver disease severity? Liver biopsy historically has been the gold standard for diagnosing and stratifying disease severity in most etiologies, but that doesn't help the doctors sitting at primary care level. So the non-invasive tests are really aimed to improve risk stratification at primary care. So it looks at serum markers, the APRI, which is the AST to platelet ratio, the FIB-4 score, which takes into account age, AST, platelet counts, and ALT, and then liver stiffness measurement, particularly the vibration-controlled transelastography or the FibroScan. And so if we look at a 2-step non-invasive risk stratification of patients with risk factors for liver disease in the general population, this really has a high diagnostic accuracy for detecting fibrosis. The APRI or FIB-4 score, followed by transelastography, is able to identify those patients most likely to have significant or advanced fibrosis we require further evaluation. So if you have a FIB-4 less than 1.3, this is a good negative predictive to rule out advanced fibrosis, and these patients can usually stay in primary or secondary level care. There are really simple cutoffs for transelastography. If the liver stiffness measurement is less than 8, this will rule out compensated advanced chronic liver disease. And if your level is between 20 and 25, this can be used to diagnose clinically significant portal hypertension, and these patients require screening for varices. And so patients with compensated advanced chronic liver disease due to numerous etiologies, it's been shown if your liver stiffness measurement is less than 20, with platelet count less than 150, this can be used to exclude high-risk varices. So I think non-invasive tests have actually changed how we practice hepatology. So in our own unit, in fact, most patients with hepatitis B or C would require liver biopsy before initiating therapy. And now liver biopsy is really reserved for those who have complex etiologies or diagnostic problems or have multiple cofactors contributing to liver disease. So moving now on to viral hepatitis, bearing in mind we are in 2024, the WHO goal is to actually eliminate viral hepatitis by 2030. And you'll see globally, but particularly in Africa, we fall well behind this goal. The surface antigen model prevalence is 5.8% in WA-Afro region, and Afro region actually accounts for 63% of all new hepatitis B infections. So it's estimated about 65 million are infected, but only 2.7 million have been diagnosed and only 0.2% treated. And we need to remember that hepatitis B is entirely vaccine preventable. This is actually a cancer-preventing vaccine. But only 15 African countries have implemented that burst dose vaccine, and 18% have time-less coverage. And this is catastrophic because if you acquire hepatitis B as a young child under the age of 5 or mother transmission, your risk of developing cirrhosis or liver cancer as a young adult significantly increases. We're also falling behind the target of the 90% hepatitis 3 vaccine coverage at 72%. So where are we in South Africa? We obviously have made great strides. Prior to the introduction of the vaccine into the EPI schedule in April 95, we had a 9% prevalence, but we're now sitting at about 3.5% or 3 million being infected. But once again, only 20% have been diagnosed and an estimated 3,000 treated. And so we look at the timeline of the antivirals. You can see it actually starts when I'm in 1990 when I'm a registrar. And at that time, we only had access to interferon, later on pegylated interferon. But the important thing about interferon, it only applied to a limited number of individuals. Those who were young, had a low viral load, and had evidence of active necroinflammation. And that is not the patients that we see. Importantly, the impact of the nucleoside analogues on the ability to transplant patients was immense. So prior to the access of that, we were transplanting patients who unknowingly were hepatitis B IgG core antibody positive and would have hepatitis DNA incorporated into the hepatocyte genome. And these patients, unfortunately, with immunosuppression, developed severe de novo hepatitis B and the devastating consequences of cholestatic fibrosing hepatitis. And many of them lost their graft within 1 year. And that really put a brake on transplanting patients with hepatitis B and also utilizing grafts who are IgG core antibody positive. But by 2008, we have tenofovir, and in 2016, TAF. And the benefits of tenofovir is it has a high barrier to resistance, and particularly TAF, which is a prodrug, can be used in the setting of renal impairment and osteoporosis. But we want to achieve a cure. So the real quest is to develop this functional cure where you have undetectable surface antigen and unquantified DNA 24 weeks after completion of a finite course of therapy. But to do this, we need to actually address several places in the life cycle of the virus. The ability of the virus to enter, but particularly this persistence of the CCC DNA and DNA integration to the genome, which promotes the ongoing production of surface antigen and ongoing infection. We need to be looking potentially at the encapsulation and release of the virus. And so we need to actually look at a combination of agents which address the entry, address the development, suppress the production of CCC DNA and integration of DNA. But importantly, we also have to use drugs that can actually adapt the immune system. So this is going to require a combination of drugs. But once again, these trials are difficult to manage. They need to be done in Africa, and the treatment actually needs to be available and cost effective. And then recently, last week, we heard about this very interesting future development of gene editing with the CRISPR-Cas9-mediated gene editing, which potentially can actually decrease total liver hepatitis B DNA and the CCC DNA. So in terms of hepatitis B, there's a lot coming in the future, but we need to make sure that the patients who need it in our continent have access to this. And then hepatitis C. So when I was a registrar, this was known as non-A, non-B, and remained like that for many years. And so hepatitis C in 1989 was discovered as a cause of transfusion-associated liver disease. And Harvey Alter, Michael Houghton, and Charles Wright in 2022 received a joint Nobel Prize for the discovery. If we look globally, there's about 58 million infected and 9 million in Africa. In South Africa, it's just under 300,000 who are infected, and we have a seroprevalence of 0.4%. But our key populations are particularly infected. Those who inject drugs have a 46% prevalence, and of note, 70 to 85% of these patients are viremic. We are a pan-genotypic country, and we have a bimodal distribution between 20 to 39 years, usually driven by our key populations, and then 50 to 70 years, and that's usually in association with previous unsafe medical practices or blood transfusion. But once again, only 22% have been diagnosed and less than 1% treated. And we need to remember this is against the background of having really effective therapy. And once again, if we look at this timeline of therapy, In 1991, once again, when I'm a registrar, we have standard interferon. By 2001, we have pegylated interferon and ribavirin, and this took the success rate from about 20% to 50 to 70%, depending on what your genotype. But now, in 2024, we have all oral direct-acting antivirals, which have a sustained viral response or cure rate of greater than 95%. They are pan-genotypic regimens, and they're short, 8 to 12 weeks with minimal side effects. But once again, we need to see what drives the costs of these drugs. So I think all of you remember in 2015 that Sovaldi or Savosvir cost $1,000 a pill, for a 12-week course costing $84,000. And so we need to remember that this is really not sustainable. And so Egypt really led the way in terms of actually introduction of generics, developing cheap diagnostics. And in October last year, the WHO awarded the gold tier as being on the path to elimination of hepatitis C. And their lowest Sofosbuvir price, 12-week price, is $29. And they've managed to actually screen 60 million individuals and treat about 4 million over a period of 4 years. So this is what is achievable if you have ability to actually screen with appropriate diagnostics and have treatment that's actually affordable. But just looking a little bit closer, Rwanda is actually projected to achieve elimination by 2027. And over 4 years, they managed to screen 7 million individuals and treat 60,000. And once again, they have reasonable dose costs for their antivirals. And then we need to remember hepatitis D. This is often the forgotten virus. It's a very interesting virus. It's an effective virus. It requires the surface antigen envelope in order to replicate and enter the hepatocyte. And it has an accelerated progression to cirrhosis and liver cancer. It's estimated that about 1.6 million infected in WHO Afro region, with very high prevalence in Western Africa at 7% and Central Africa at 26%. And we now have treatment. Bulevirtide is the sodium taurocholate co-transporting polypeptide blocker, which prevents the entry of the hepatitis B and D virus into the hepatocyte. It has been shown that in terms of giving this 2 or 10 milligrams bulevirtide subcut daily for 144 weeks, they were able to reach the primary endpoint in 48% of patients, and this was combined virological biochemical response at 48 weeks with undetectable DNA, hepatitis B RNA levels, and normalization of ALT. But once again, there's a catch. If we look at the cost per month, it's $13,500, and it's not known how long this treatment is required. So once again, we need to address this inequity that we find. So if you're going to address potential elimination of hepatitis B and C or D, you need to have guidelines. So the Division of Hepatology has been instrumental, particularly under Professor Ralph Kirsch, together with Mike Q, of introducing the hepatitis B vaccination into the EPI schedule at 6, 10, and 14 weeks. And we've seen how that's decreased the prevalence from 9% in the 90s to 3.5%. We've been clinical leads in drafting those first national guidelines, and they were adopted in 2019. Unfortunately, in 2023, the Department of Health has introduced surface antigen screening for pregnant women and targeted birth dose vaccination for neonates born to surface antigen pregnant women. But our next battle really is to ensure that all neonates are vaccinated against hepatitis B. It's a simple vaccine. There's already a schedule to give vaccinations at birth, so there really should be no reason to not be giving this, which is a vaccine, which is a cancer-preventing vaccine. So in terms of the WHO guidelines, the important thing is if one going to actually achieve elimination, these guidelines need to be applicable at primary healthcare level. And so the new guidelines provide 4 options that actually capture at least 50% of individuals infected with hepatitis B. They use a simple, accessible NIT measurement of fibrosis, the APRI score, taking it down to 0.5 so that you won't miss F2 fibrosis. And importantly, you will see it's no longer dependent on the ability to measure the DNA level or the e-antigen status. So foremost is actually to identify those with significant fibrosis and to start treatment regardless what your DNA level is, your e-antigen or your ALT. Taken the viral load down to 2,000 with just 1 abnormal ALT level. And that's important in the setting of Africa where often our viral loads are low. And then importantly, the presence of any cofactors, so immunosuppression, family history, co-infections, MASLD, and extrahepatic manifestations. Once again, regardless of what your DNA levels are. And then I think the very important thing, if we're going to actually address this, is that the ability, in the absence of DNA quantification, to actually initiate therapy if you have a persistently abnormal ALT. So I think these guidelines go a long way to demystifying management of hepatitis B. You no longer have to worry about those 5 phases, which hepatologists love, but cause great confusion generally. And I think when this hopefully will make a major impact in actually combating hepatitis B. Mark Sondrup has also represented the division in terms of guidelines development for hepatitis C self-testing, and has been part of the external review group for the hepatitis B guidelines in 2015 and 2024, and part of the strategic advisory committee, so playing a major role. And then metabolic dysfunction associated steatotic liver disease. When I was registrar, this was barely mentioned and probably was a cause of many causes of cryptogenic cirrhosis. So globally, this is the leading cause of chronic liver disease, with 38% of the world's population being affected, or 1.7 billion people. And in sub-Saharan Africa, it's thought to have a 13.5% prevalence. But this is probably an underestimate if you think of the rising prevalence of obesity and diabetes. So the new nomenclature has an umbrella term of steatotic liver disease. And this consists of metabolic dysfunction-associated liver disease, a combination of MASLD and increased alcohol intake with MET-LD, alcohol-associated, those with specific etiologies such as drug-induced liver injuries or Wilson's disease, and then a small group which are cryptogenic. So you diagnose steatotic liver disease based on the presence of steatosis, either histologically or on imaging, and then all you need is one of these cardiometabolic risk factors to actually define MASLD. So BMI, fasting glucose, blood pressure, triglycerides, and HDL. And if you're on any treatments for any of these, that is enough to actually diagnose MASLD. But I think very importantly, pragmatically, is this entity of MET-LD. We know that people take alcohol. And so it's very important to actually understand that the combination of MASLD and alcohol is associated with a much more aggressive disease, and one needs to address this with our patients. Importantly, we now can have multiple etiologies, so you can have MASLD plus autoimmune hepatitis or viral hepatitis. And importantly, it recognizes as driving metabolic risk factors for the progression of disease. So why is it actually important to understand about MASLD? So we know that the liver-related mortalities increase, but cardiovascular disease remains the leading cause of death. And so if we look at the pooled mortality rates, it's 12.6 all-cause mortality and 4.2 for cardio-specific mortality. And we can see from the slide all the areas where MASLD affects, and particularly there's a significant morbidity and mortality. And so once again, hepatologists, gastroenterologists, physicians can't deal with everybody with steatotic liver disease. So we need to actually enable this management to be at primary healthcare level and then be up-referred. So once again, we look at that non-invasive test, the FIB-4. So if your FIB-4 is less than 1.3, you can review every 1 to 3 years. If it's between 1.3 and 6.7, you can intensify the management of comorbidities, or you can fibroscan. If it's more than 2.67, you definitely should be fibroscanning. And if the fibroscan levels are less than 8, you can either continue to intensify or you can actually refer. Or if it's greater than 8, you actually refer upwards. And then you will decide whether you need to actually do a liver biopsy or not. So I think this is very easy and simple to follow, a very simple scoring system of FIB-4 which you can use at primary care level. And so we know it's important in terms of non-pharmaceuticals, in terms of exercise, diet, weight loss. We now, for the first time, have a FDA-approved drug, resmetirom, which is the thyroid hormone receptor beta agonist. And this has been for patients with up to F2 and F3 fibrosis, but not with cirrhosis. But importantly, we need to remember the appropriate management of these metabolic risk factors that are driving MASLD. So in type 2 diabetes, we have the GPL1 receptor agonists, the co-agonists, the SGLT2 inhibitors. Remember that statins are not contraindicated in chronic liver disease if you need to manage dyslipidemia. And in terms of obesity, the GPL1A and co-agonists, and importantly, bariatric interventions we shouldn't forget. So I think, once again, we need to ensure that our patients actually have access to these appropriate medications for these cardiometabolic risk factors. So just briefly looking at resmetirom, which is really looking at treatment of non-cirrhotic NASH with up to F2 fibrosis. And what they showed that 25 to 29% had NASH resolution with no worsening of fibrosis. And between 24 and 25% had fibrosis improvement of more than one stage with no worsening of the NAFLD activity score, with significant improvement in the cholesterol levels. And then always just to remember, we tend to forget about the role of bariatric surgery. So this is a trial looking at patients with histological confirmed NASH with high BMIs, and they looked at the primary endpoint, histological resolution of NASH without worsening of fibrosis at 1 year. And it showed the severity of bariatric surgery. They look at the calculated probability of NASH resolution with Roux-en-Y gastric bypass, is 3.6 times greater, and with sleeve gastrectomy, 3.67 times greater than lifestyle modification. And you can see 56 to 57% had NASH resolution without worsening of fibrosis, and between 37 and 39% had improvement at least one stage of liver fibrosis without worsening of NASH. But this cannot be used in patients with cirrhotic. You really need to be careful that they don't decompensate. So then briefly moving on to autoimmune liver diseases, particularly primary biliary cholangitis, which is a chronic inflammatory autoimmune cholestatic liver disease, resulting in loss of intralobular bile ducts and eventually biliary cirrhosis. So since the 90s, the only approved first-line therapy has been ursodeoxycholic acid. We now have a new drug on the block, elafibranor, which is the dual PPAR agonist, utilized in patients with either inadequate response or unacceptable side effects to urso. And they looked at the primary endpoint, which is the biochemical response, an alk phos level less than 1.6 times the upper limit of normal, with 15% reduction from baseline, and normal total bilirubin levels at week 52. And you can see 51% actually achieved that biochemical response, with really no difference in adverse events between the placebo, between urso alone and the drug. So once again, this is an important progression in treatment for primary biliary cholangitis, but it remains to be conceived whether we actually will be able to afford this. And then the devastating complication of liver cancer. This is the second leading cancer in men and third in women in sub-Saharan Africa, has a median age of presentation in sub-Saharan Africa of 45 years, and a median survival of 2.5 months due to being often a multifocal inoperable. And so we look at the etiologies in hepatitis B in Western and Sub-Saharan Africa, hepatitis C in Central Africa, B and C in Eastern and Sub-Saharan Africa. Remembering that hepatitis C is curable and hepatitis B has a vaccine-preventable disease. And so this is really, really distressing because hepatitis B is accounting for 66% of viral hepatitis-related HCC in Sub-Saharan Africa. And important to remember that 40% of patients with hepatitis B-related cancer are actually not cirrhotic. So we tend to be a little bit nihilistic when patients present with HCC, and I think we need to change that approach. We need to realize that if you actually do early screening of patients with chronic liver disease, which is why you need to identify these patients, you can pick them up early, and then you decide in terms of are they suitable for curative therapy, so ablation, resection, transplantation. If they're not suitable for curative therapy, can you actually promote prolonged life beyond 2.5 years? Are they actually accessible to transarterial chemoembolization? Once we move beyond that into stage C, we require systemic therapies. And then terminal, it's important that you have access to best palliative care. And this needs to be part of the multidisciplinary team. So this multidisciplinary team requires hepatobiliary surgeons, hepatologists, oncologists, radiologists, transplant surgeons, pathologists, and palliative care physicians. And I think importantly, we need to realize we've actually progressed from sorafenib in 2006 and earlier than that to now access to dual therapy with Azito and Bevo. And if we look at the overall median survival for sorafenib, it's about 9 months and 90 months with dual therapy. So we need to once again advocate for access to our patients to systemic therapies, remembering that unfortunately 70% of individuals present with stage D, only 6% are treated with curative intent, and 80% are treated with best supportive care. And so I think if we identify early, screen early, we can prevent this dismal outcome. So just giving you a few insights into our own experience with hepatocellular carcinoma. Sandra Sobczak has recently put out the results of actually following almost 680 consecutive cases between January 1990 and February 2024. 74% were male, the mean age was 50, and 50% were due to hepatitis B. Once again, if you look at the curative intent in terms of either resection, ablation, or transplantation, only 18%, with 82% requiring palliative care. And you can see from all these pictures around it, if you're going to manage liver cancer, you need a team. Your hepatobiliary surgeons, your transplant surgeon, interventional radiologists, intensive care, anaesthetists, and importantly, palliative care. And so I think this is an important slide because it tells you there's much for us to do, and we need to identify these patients and get them into care. So what about the role of regional collaborations? We've heard a bit about this. GASA was inaugurated in 2017 by Chris Cassanides and Sejan Oja. Really an association of hepatologists and gastroenterologists working in the sub-Saharan region, really addressing challenges in clinical practice and research focus with annual liver updates. And this has really been driven very actively by Chris Cassanides. And so what is the impact of this collaboration? We've had a number of publications published under GASA, viral hepatitis, fatty liver disease, liver cancer, and more recently cirrhosis, and really showing the really importance of collaboration across the region. In 2023, SOLA was established, and this was really to once again further develop this community of hepatology scientists and clinicians throughout Africa. Annual COLDA meetings are actually held, and we really represent all 5 regions of Africa. And I think one of the importance of these collaborations is what are the spin-offs. So the HepSnet, with the Hepatitis B in Africa Collaborative Network, realized after one of the COLDA meetings that there's very limited published data on the natural history of hepatitis B in sub-Saharan Africa. And so 8 countries, 12 sites, looked at about 4,000 hepatitis B patients, and they really assessed the performance of their non-invasive markers, the APRI score, amongst African chronic patients with chronic hepatitis B. And they found that the previous WHO recommended APRI score of greater than 2 actually missed 50% of cirrhotics. And this was really quite instrumental in actually determining that low threshold of 0.5 in the new WHO guidelines to actually not miss patients with advanced fibrosis. They've also developed a novel simplified scoring system, looking at AST, ALT, and platelet count, looking at simple clinical parameters, first-degree family history, clinical diagnosis of decompensed cirrhosis. And if your score is greater than 2, this has a 78% sensitivity and 87% specificity in determining eligibility. And so I think what this really shows the importance of validating treatment criteria and scoring systems within different regions. And then this holy grail, the bioartificial liver. So this was a collaboration between University College London, led by Claire Selden and her team, UCT with liver, departments of anesthetics, surgery, neurosurgery, and animal unit. So previous bioartificial livers were dependent on hepatocyte monolayers, which really lose differentiated function quite rapidly. And so what we were involved was in testing a clinical cell bioartificial liver machine, which contained hepatocyte biomass derived from a hepatoblastoma cell line, cultured and encapsulated and alginate in 3D organoids. And the benefits of that enables those hepatocytes to talk to one another. And we use a porcine model of acute liver failure where we induce surgical ischemia. And we showed that these hepatocytes were active. They could produce albumin, prothrombin, fibrinogen, alpha-1 antitrypsin, and alpha-fetoprotein. And so this is the HepiCan, the bioartificial liver at its present form. And what we showed in these initial pig trials was that it improved important prognostic clinical liver parameters, improved coagulation, improvement in acidosis, reduced the vasopressor requirements, improved oxidation, but importantly, reduced intracranial pressure. So at present, Claire Selden and her team are in the process of completing the device regulatory requirements for submission to the UK Medicines and Healthcare Products Regulatory Agency for initiation of clinical acute liver failure trials. And then, as we've heard, there's telementoring outreach programs, I think Mark and I continue to learn every month when we run these programs. And so we've been really very privileged to be able to run these programs supported by Jeff Dusheka. And we've managed to reach about 20 sub-Saharan countries. We now involve the correctional services, the harm reduction programs, and this enables facilitating discussion on complex viral hepatitis cases. And as we heard, we were able to expand this during the COVID period, and Mark and I were able to facilitate Graham Mankey's in running these webinars, which he had a total of about 41 webinars. We addressed the global and local epidemiological updates and looked at COVID-19 clinical and research updates. And then in total, there were about 14,000 attendances across 45 countries and 5 continents. But we need to always acknowledge really what the backbone behind these webinars were. So Sahana Ragal, Claire Jeffrey, Mohammed Johnson, Cheryl Valentine, and Karen Fenter. Without their support, none of this could have been possible. And then the role of artificial intelligence. I thought I had to mention this, although you know me, I'm glad that's the next stage. But in fact, it has been useful in terms of imaging, histology, identifying risk patients for fibrosis, and predicting outcomes. But I think one always needs to remember the clinician, I think, should be at forefront, and you should never lose touch with the patient. So I think Mark and I will probably consider our greatest achievement is actually to establish hepatology as a subspecialty. It took Mark and I 10 years of motivation. We were finally recognized in 2018. And Unesco Geller was the first to be awarded the MPhil Advanced Hepatology and Transplantation, looking at hepatitis C prevalence in HIV-infected heterosexual men and men who have sex with men. And we have now 2 fellows in training, Dr. Sandy Masenya from Botswana and Liz Gatley, our own from South Africa. And Sandy's looking at the clinical outcomes of patients with primary sclerosing cholangitis, and Liz is looking at an NIT-based evaluation of the 5-year outcomes of patients with E-antigen-negative infection. So I think all these facts are wonderful, but one's journey is really enriched by a tapestry of daily interactions. So thanks to my colleagues across all disciplines, the patients, porters, messengers, clerical, allied health staff, pharmacy, the hospital executive, administrative staff, nursing, laboratory, teaching staff, and security, and all our registrars and fellows. And I think what really makes my day-to-day life very positive is that many of the messengers, porters, clerical staff, laboratory staff, I've actually known since I was an intern or a junior registrar, and I'll miss that interaction. And then importantly, the J floor, the administrative, teaching staff, and finance staff, I interact with you on a daily basis. You help me always, and particularly really indebted to all of you, particularly in terms of the teaching and admin. And then to the Sondra firm, to my comrades in arms, I think particularly on a busy intake and during COVID, I often felt when I was going into battle, but we always knew that each other had our backs. And then the medical registrar is really the backbone of the G floor. The liver clinic has been here just as you come into the Kruiskir, been there since 1994. And this is a picture of us all in our youth. And so I really need to acknowledge, and I think you can see here, liver clinic or the liver unit has a reputation of having lifers actually who work for us. Shahid Abrams, who's been our clerk in the liver clinic since 2013. Fozia Francis, who has been with me since 2004. She's the powerhouse behind all of us. There's every single patient, when they come, when they don't come, what their excuses are. And so you can't keep anything from Fozia. Sister Rhoda True, who really was instrumental in really establishing a very functional liver unit, was with us from 2006 to 2018. And our newcomer, Sister Burrows, who started in 2023, who I think sometimes thinks that we're all a little bit crazy, but she accepts us, I think. And then the E12 transplant unit. I mean, we've heard the success of liver transplantation, but in fact, that involves a major interaction of many, many people. Our transplant coordinators, dietitians, general assistants, our nursing staff, and importantly, our social workers, Andre de Vos and Lungile Shaguli, who actually has been really essential to actually assessing the needs of our patients, telling us these patients are in trouble, these patients are going to really struggle, how we can actually help them, and importantly, not only help our patients, but have been major supports to all the clinical staff within transplantation. So I thank all of you. And then I'm almost coming to the end, my liver unit colleagues. So Henry Awatsi was with us between 1999 and 2013, was really beloved by the patients. He's still very missed. And he made major insights to how one actually manages and diagnoses the outcomes of autoimmune hepatitis. Nelesto Gugela, who started in 2012, who is passionate about ensuring equity for all patients, and together with Mark will take the unit forward. Professor Stuart Saunders, who first came to work in the liver clinic in 1997, and actually was at a research day where he said, I was standing with Prof. Kirsch, and he said, could he come and work in the liver clinic? And my first internal response, oh my goodness, I'm going to have the Vice Chancellor next to me. But what could I say? It's an absolute pleasure, Prof. Saunders. So, Prof. Saunders really was an amazing individual. He was initially a very senior colleague, became a friend and a mentor, and was really always very supportive of the liver unit, and particularly our journey to becoming a subspeciality. And we really miss him every day. And then to my partner in crime, Mark Sondrup, since 2002, Mark. I think we have very different personalities. But I think we've traveled an amazing journey together. I think we've achieved many things, and I think we still get up every morning and talk to one another, which I think is testimony to our friendship, our collegiality. And Mark, I couldn't have done any of this without you. And then finally, thanks to my family, to Jonathan, who has known me since the age of 15, who definitely knew what he was getting into, but has supported me along this journey. And then to my children, Rebecca, Lawrence, and Julian, of whom I'm inordinately proud. And without all of you, I could not have actually achieved this journey. And so I thank you very much. And then finally, just a word. I think I need to thank my parents who never saw me become a doctor, but I think instilled in me if you have resilience, hard work, you can achieve anything. And so I hope to leave that with you all, resilience and hard work. And then before I get to my last slide, I'm going to ask Rebecca to... Yeah.
I'm not going to give a very technical speech, obviously, but I'll just give from our perspective as the family and what an honor it is to have Wendy Spearman as my mother. And I'm just going to share a few stories of how we know her. And, I think she's ended now with her parents, and key to this is that she knew my mother from a very young age that she wanted to be a doctor. And as she mentioned now, when she met my father at age 15 and my dad was 17, she told him already she was going to become a doctor. She had limited time for teenage romance. So it's clear that the determination has been there from the very beginning. And this would be a quality that would become really her strength, as she mentions now, as she's faced great losses in her family in her early teenage years. And it helped her, as she mentioned, when she was a registrar, going through 10 months in surgery, thinking this is not for me, but then it was great to help her in a transplantation process. The determination to expand clinical understandings of liver disease in South Africa and globally been seen in her determination to teach with ethics, care, and fairness, and it's been seen in her determination to give quality care to all patients she sees. And this determination has also meant that patients can be quite determined to find my mother as well. Once, while we were camping at Wilderness on the garden route, some patients managed to track her down to the very campsite. This was after accusing her of putting her name under a false name because she wasn't Wendy Moore, she was and this was also after clearly their determination to find her by putting news bulletins out about her in the period before cell phones. Patients also find her in many other interesting ways, I think. During my work in community health activism in the rural Western Cape and Northern Cape, she somehow found herself advising me on how to support rural health activists and farm workers with different health struggles. She's found herself advising all of us on health issues of ourselves, our friends, our colleagues. She's even found herself, as many have, on flights when new unknown patients find her while they are falling sick in the skies across the Atlantic Ocean. And the rewards of this have been mixed. In this last circumstance, the airline gave her a bottle of champagne, which she was quite pleased about, but which unfortunately got confiscated during the transfer. many of the patients might never see her again or find her through the Fruitisphere Heroes Facebook page. But really what I think it shows is that being a responsive and attentive doctor comes with many unspoken and often unacknowledged responsibilities that are rightfully an important part to be celebrated and valued in these moments. Even if the champagne might get confiscated, the legacy will still be there. And I think perhaps because of this responsiveness and accountability, she also was quite hesitant in the 90s to get a cell phone. She never wanted one. She really was against it and was very happy with her pager. And then eventually she got one and really didn't want to give out her number. This of course never worked, and the blessing and joy of that and gift of that is that she receives photos of patients thriving across the years who she supported. She also had a similar response to laptops, never wanted laptops. And I would like you all to imagine if she'd been able to do this massive research output without this trusty laptop by her side. So now we can track exponentially how her research with many, many colleagues has increased since she's gone. So I think for myself, I speak here, it's really been only in the last 10 years or so that I've really fully realized how prolific and impactful my mother has been in her profession. We sort of realized that when her feedback to her PhD was that it was great, and it only had 2 errors. One of them was the spelling of aspirin. So what we saw growing up really as a family was how much her patients appreciated her, particularly those who were under care for many years. And I think back on patients like Alavia, Patty, Julie, the children recipients of liver transplants, and countless others who also became part of our lives as a family growing up. Of course, we also experienced my mother's working life in a unique way as a family. It was, and maybe still is, rare to have a mother who works as hard as she does. And my parents' relationship has been really inspirational in their mutual support for one another. And in how they have also cherished and supported the support that they receive from phenomenal caregivers who help take care of us at home. With this collective care and her own determined balancing, my mother made sure she never missed any school performance, which I had many in school. Never missed any parent-teacher evenings. She watched our sport matches. She gave us moral and emotional support on parenting through tumultuous periods of growing up. Again, I had many of those. And dropped us off at school, helped us make posters through constant school projects we had. And all while consistently working in the public service 5 days a week from 8 to 6 with general rounds and weekends, most weekends. Also while achieving many personal dreams and professional goals and setting an example for many. She worked many Easter and Christmas weekends, and indeed we missed her on some of those lunches or mornings and some of the in-between moments, but really in the end none of that has ever mattered. And she always made sure that we had plenty of ritual as a family that she also initiated, and always prioritized quality time with the family, whether it was around the daily dinner table, weekend, Sunday night fish and chips, or during the very many special family holidays we had. And so we had a mother as a doctor, which has been a massive blessing for all of us. And also in our healthcare, as my mother looks after all of our medical ailments, of course. And that includes those within her speciality and those beyond her jurisdiction, which has led to some funny moments. My father, when he was in the initiation of his law degree, really he had tick-bite fever 6 weeks before writing his final LLB exams. He was misdiagnosed at the time and couldn't be treated, and my mom was the one who was caring for him during this time. And you see him up and studying for all his exams, and the first day he was able to stand really and get out the house was to write those final exams. Another side of that story is once when my brother fractured his arm, and with a very stoic approach that might be common on one side in the family, only complained that it was quite sore, and so we all thought it was just bruised, and in fact he woke up the next morning with a fractured wrist being diagnosed. So I think being the child of a doctor or a nurse or any healthcare provider, but particularly pediatric liver specialist, is a real struggle sometimes to get medication out of them. We really grew up on Panado syrup, that's the main alleviation, as well as generally healthy foods and exercise, and definitely no supplements or and in fact, the only times when I was allowed to go to school was when there was extra studying to be done, and my mom wanted me to work at home rather. And with this, it's been very clear that she's always believed in our capacities and determination. She's encouraged us to strive for our best and always supported us where we found ourselves. I knew she would have liked there to be another doctor in the family, but I know that her profession has been integral in shaping my activism and advocacy and community organization efforts around service delivery and health justice. And I know she's happy that we are all hard workers, particularly my brothers, and that we've all followed each our interests and goals as she has done for herself. She inspired me to see work well done as an important part of one's personal dignity, to commit to fairness and to give service, and to live with humility and integrity and care for others. In the place of any flashy charm, my mother has a great sense of humor, a voracious intellect, and an extraordinarily generous heart. While she has achieved an incredible amount of accolades and professional growth throughout her career, I think I really must admit that this part of her life, here being a clinician and a dedicated doctor and carer at Hepatology Hospital, is one that I'm most proud of and inspired by. How she has dedicated her life to service and care through public health provision in South Africa alongside most of you here. She has made deeply considered decisions about how to live her life and the values she lives by that are inclusive, honest, radically caring, and I know her legacy of British here will lie in her dedication, her rigor, her attentiveness to patients and to detail, and above all, her commitment to quality care for all South Africans, regardless of their creed, race, caste, or class. Thank you for celebrating her today, and I hope that the legacy will live on in new ways through all of your service too. And I wish my mother really, truly the best as she embraces her new chapter forward.
Thanks, Bex. At least didn't give away any major secrets. And so we look to the future. The journey really continues. We need to really address that ongoing burden of viral hepatitis and liver cancer, the increasing burden of MASLD, and we need to address this cost of diagnostics and therapeutics. But hopefully in the future, there'll be time for travel, the beach, snorkeling, and camping. And I thank all of you for being here and being well over time. And then just really to thank